Hi, I'm Paul Graham, CEO of MedTech Innovator. I'd like to welcome you to the 2021 Leaders Forum. In a series of events this week, prominent thought leaders will discuss a range of topics related to health equity. I'd like to thank our premier sponsors, the Life Science Angels, Moss Adams, Wilson Sonsini, Goodrich and Rosati, and my company, MedTech Innovator, for sponsorship of this year's Leaders Forum. The Leaders Forum was set up in 1995 with the aim to raise funds to prevent and cure diabetes and improve the lives of everyone affected by it. Donations are incredibly important in the fight against diabetes, and that's where we need your support. I'm pleased to say that you can double your impact this year thanks to an anonymous donor. Every donation will be matched dollar for dollar up to $25,000. I encourage you to donate at diabetes.org/leaders-donate. See what we did there? Leaders donate. Please make your donation now. You are in for a treat today, as this is the first of 3 outstanding virtual events in the Leaders Forum series this week. I'd like to begin by introducing Dr. Suneil Koliwad as the moderator of today's discussion with Dr. Diana Alba. Dr. Suneil Koliwad, MD, PhD, is an associate professor of medicine and the chief of the Division of Endocrinology and Metabolism at UCSF and runs the Koliwad Labs in San Francisco. Dr. Koliwad holds the Mount Zion Health Fund Distinguished Professor in Endocrinology and is the Gerold Grodsky PhD JAB Chair in Diabetes Research. Dr. Koliwad is a longstanding volunteer leader of the American Diabetes Association. He served as past medical president of the Northern California Community Leadership Board. In addition, Dr. Koliwad serves on the ADA Peer Review Committee for the research grants and helped establish the 2017 to 2019 Standards of Care. And for today's panelist, Dr. Diana Alba is an assistant professor of medicine in the Division of Endocrinology at the University of California, San Francisco. She is board certified by the American Board of Internal Medicine in the subspecialty of endocrinology, diabetes, and metabolism. Her primary research is focused on the pathogenesis of both obesity and diabetes in order to find ways to reduce the deleterious metabolic outcomes in individuals from vulnerable populations. One of her projects addresses why individuals of certain ethnicities are prone to developing obesity-associated metabolic disease despite having a relatively low group-level body mass index, or BMI. In this conversation, Dr. Koliwad and Dr. Alba will discuss the importance of health disparity research and how.
Hi there. Thanks for that introduction. I really appreciate it. And thanks to all of you for joining today. My name is Suneil Koliwad, and as was stated, I'm at the University of California, San Francisco. And I think briefly, one of the things that's always drawn me to the American Diabetes Association, both as a volunteer and as a research scientist, is the incredible breadth of focus that the American Diabetes Association attempts to embrace in terms of mission delivery, advocacy, research support, clinical care and guidance, and an array of other areas, including advocacy at the federal level for funding for diabetes and related disorders across the board. And I have involved myself over the last 15 to 20 years now in all of those areas, helping to push the ADA's mission forward. And one of the areas that I think is really emblematic of how forward-thinking the ADA has been is its efforts in bringing to light, creating awareness around, and supporting research, clinical care, and the visionary thinking required to understand and deal with disparities in diabetes, both in terms of diabetes prevalence and trends, and also trying to mitigate the effects of diabetes and reduce diabetes rates in the United States. And with that in mind, I would also at this point like to introduce my colleague and friend Diana Alba. Diana is an endocrinologist. She works at the San Francisco General Hospital, the Zuckerberg San Francisco General Hospital and Trauma Center, which is San Francisco's flagship public health hospital and associated healthcare system. And in that capacity, she is really confronted every day with the immense disparities that are attendant with diabetes in a large city and county. And what she has done with her colleagues at the General Hospital in creating ways to deal with diabetes across very diverse populations, both genetically as well as socioeconomically, is really impressive. And then separately, Deanna's research also dovetails with this in trying to understand and translate important aspects of what makes different groups of individuals differentially prone to diabetes and related metabolic disorders, so that we can think of much more personalized and precise ways of preventing diabetes and even treating or reversing diabetes depending on the individual. And that's not something that currently is standard of care, but we hope that it one day will be. So with that in mind, thanks for joining, Deanna.
Thank you, Suneil. Happy to be here.
So we're going to be sort of talking about some of what we think are really relevant topics in the area of healthcare disparities vis-a-vis diabetes. And I think it's really appropriate to have this discussion this week because the Leaders Forum from the ADA this year is aligned not only with a common theme of technology and how technology can be associated with improving diabetes, but also the intersection of technologies and the application of technologies given really vexing problems related to health disparities. And how can we optimize the role of technology in a world where access and the benefit to technologies is not equally placed across all individuals. So with that background in mind, let's get started. I think, one of the things that individuals attending today's session in the Leaders Forum might want to know is how does the money that the Leaders Forum and the ADA raises contribute to the work that people like you and I do and to the ADA's research portfolio overall with respect to the diverse ways that diabetes manifests in our community. And so maybe we can start by just letting folks know what your trajectory has been, where you started, and where ADA funding fit into your career development trajectory and got you to where you are now.
Yeah. So, like I just said, I'm an endocrinologist, so I'm a physician. But when I came to UCSF to complete my fellowship in endocrinology and diabetes, I got involved in research in Suneil's lab. And when I was transitioning to become faculty, that's when I had some issues with funding. And so I applied for an ADA grant and I got a minority fellowship grant that helped me for 3 years. I think that ended maybe last year. And it was a great way for me to transition to become faculty, to start my research in this kind of great topic. And it helps people like me and helps a lot other people who are trying to kind of establish their research to answer a lot of the questions that we have about diabetes care, understanding pathophysiology of the disease. And so grant funding is really important for researchers. Doing research is expensive. And so having the support of the ADA has been really great for my career. One of the questions, and I think Suneil kind of mentioned this, is as an endocrinologist, I've seen that our approaches to prevention and diagnosis and treatment of type 2 diabetes in many of our patients is suboptimal. And so that's kind of one of the questions that I've been trying to answer with Suneil as far as particular populations. And so I can kind of talk a little bit about my research right now. I've been working on a project where I'm trying to understand why people from a specific ethnicities, South Asians, East Asians, some Hispanics, actually have an increased risk for type 2 diabetes and obesity-related complications, even though they're not obese. They might actually be considered lean or a little like overweight, but they actually already have type 2 diabetes, cardiovascular disease. And so there have been a lot of data or studies looking at that. And there is some like understanding that it might be related to fat distribution, but actually we've been trying to understand the relationship with the fat itself. And so we do this like mini liposuctions. We get a little bit of fat from the abdominal area. And then we study the fat tissue and try to correlate it with the risk for someone developing type 2 diabetes. And so again, the support from the ADA has been great for my career and from my work. We have a good number of papers published related to this and a lot of kind of great data coming up.
Yeah, I think, just to underscore some of the highlights there, I think that that with respect to ADA-funded research, there are kind of three pillars that that Dr. Alba highlights that I think are really worth underscoring. One is biology, basic fundamental understanding of the factors that dictate diabetes risk. I would say that until the last decade, that kind of focus has really been at the cellular level, but the people, the human beings from which those cells come and those molecular pathways are probed, in reality are highly diverse. And none of that diversity, either at the level of the individual or at the level of individual molecular pathways, was ever really formally taken into account. And therefore, traditionally, when we've tried to translate those learnings into clinical practice or into new drug treatments or into new preventative approaches, there have always been a notable population of responders and non-responders. And therefore, clinical translation in diabetes has notoriously been an inefficient process because there's always a population of people that seems not to benefit from the intervention that we're trying to make. Precision medicine, on the other hand, and that's what Dr. Alba is working on really, tries to customize and target the approach to the individual. And we are trying to understand aspects of that basic biology that differ from person to person so that we can align the translational approach to the individual in question. So that type of funding, the fact that Dr. Alba got a postdoctoral fellowship to study this particular area shows that the ADA, even in the last 5 to 10 years, was already on the same page and thinking about things the same way. Because, of course, Dr. Alba's grant proposal idea was one that received positive response and was funded. And that's brings up sort of the second point in my view, which is that the workforce in diabetes-related research needs to be just as diverse as the patient populations that we attempt to help clinically as well as in research. And I think that that the fact that the ADA had and has had a minority, at that time called minority-focused postdoctoral fellowship opportunity, allows us to not only approach diversity at the level of the questions we're asking, but also approach diversity at the level of the individuals who we retain and advance to probe those questions. And I think Diana is a really beautiful example of that kind of, alignment of research workforce and the advancement of a diverse research workforce, and therefore then a workforce that is incredibly focused on answering questions related to issues of disparity. And that's been, really beautiful to watch. I think that the third area, and maybe Diana, you could sort of spend a moment helping us out in this area too, is in the area of actual clinical research and clinical care. And given that you're at a public hospital system connected to a top flight university, what is the role that we have at an institution like UCSF in sort of being leaders in the area of disparities research, in the area of personalized medicine across socioeconomic strata? And what are the problems and how do you see that role manifesting as you care for probably, what I think is the cutting edge of diversity, at least in the city and county of San Francisco?
Yeah, so that's a really good point. So in our clinics, we see, I think right now we have like people who speak like 20 plus different languages. It's a very complicated clinic. The socioeconomic issue is also very important because we have a lot of our patients who are homeless, who obviously don't speak the language, who just have a lot of difficulties just even showing up to clinic. And unfortunately, the pandemic, as we know, kind of amplified this. And so the diabetes clinic at San Francisco General is pretty impressive. So we try to support our primary care doctors because they are the ones seeing a lot of these patients all the time, and they just don't have the bandwidth to kind of deal with everything. So we do a lot of education for our primary care doctors, our primary care nurses, a lot of our residents and kind of trainees. We try to reach out to a lot of community clinics to kind of help give support, give a lot of education. We are also doing a lot of kind of online or e-consults where a lot of the primary care doctors or other specialties can just ask us questions and we can kind of reply online without the patient actually have to come into the clinic, which is something that really has helped out a lot of our patients. So thinking about our population, we have a lot of people who are working people who cannot take a day off or a half a day to go to a doctor. So being able to reach them when they're at home or at work has been really, really incredible. So we can do a lot of this kind of online consults with their primary care doctors to help manage their diabetes, their insulin, to try to give them a lot of education. The clinic also have a lot of group classes, which is where we try to bring a lot of our patients who are newly diagnosed with diabetes or actually had diabetes for many years and have not been well controlled. And we have amazing diabetes educators. We have nutritionists. It's kind of like a multidisciplinary approach to try to get people to understand what disease they have, the progression, what else is going to happen kind of in the next 5, 10, or 15 years. So it's been incredible to be part of this clinic because we're just helping a lot of people, but there is a lot of work to be done. We still have a lot of patients that we need to reach out to. Unfortunately, again, because of the pandemic, we noticed that we wanted to do a lot of telemedicine, but a lot of our patients don't have a smartphone, don't have a laptop, don't have internet. And so kind of trying to reach, we had to do a lot of telephone visits. And so it's been challenging, but at the same time, it has kind of helped us understand what areas we need to focus on. And so one is kind of the telemedicine, kind of more technology geared to these patients to help them kind of reach us and reach the other specialties, and then the support that goes to kind of all of the other providers, including our nurses and diabetes educators and the nutritionists. I wanted to kind of bring up, you were talking about kind of our research and kind of the clinical research. And one of the things that the ADA grant that I got has helped me also is that Suneil and I started a cohort, a diversity cohort. So it's called the Inflammation, Diabetes, Ethnicity, and Obesity cohort, IDEO cohort. And that was pretty much established to study these questions that we have about diversity, ethnicity, and how it relates to obesity risk, type 2 diabetes risk. And one of the things that I noticed, so we were trying to enroll people who are Asian, Hispanic, white, African American, so different ethnicities. And initially trying to kind of recruit or enroll people who were Asian, for example, was very difficult. And it's because there was this kind of, they just, I guess, didn't trust us. There was not, it was the language issue also. So I'm Colombian, so reaching out to like the Hispanic population was a little bit easier because I speak the language. But we actually had to reach out to a lot of different groups at UCSF to kind of help us recruit the Asian Americans. So there's a lot of groups at UCSF and San Francisco General to kind of reach out to the Asian population. I think Suneil, do you mind? I think you did a TV ad, or maybe I did it, I can't remember, but we had to put ads on some of the newspapers. And so kind of doing that, reaching out to that population is what we need to do. So for example, we're trying to recruit more African Americans in San Francisco is really hard. So I've been talking to someone who does that type of research in Oakland. And so I think for us, for researchers, we have to understand that this participants and trying to kind of increase the diversity that we have in research is just not something that is going to happen because we talk about it. We actually have to do the work. We have to reach out to people. There are a lot of community programs that we need to support to kind of increase the enrollment that we have. Because the only way we're going to understand better the pathophysiology of type 2 diabetes and how to better treat it is to have this like multidisciplinary approach that includes having more participants in our studies that are from different ethnic groups.
Yep, I think that that's fundamental, and you know, you remind me of all the work that went into that, and how tough that sledding was, because, as you say, there is not a pre-prepared infrastructure to ensure diverse patient recruitment for studies or cohorts or other research, endeavors built into most health systems and or universities. The future should be associated with that kind of infrastructure so that individual PIs and labs who want to do cutting edge research don't have to sort of go it alone and figure out how to diversify their patient panels or their research participant population on their own. And I think, the ADA steps in with funds to help these projects get off the ground, but that might be an area for, the future in terms of disparities research is how do we create recruitment vehicles that assist universities and individual investigator teams in ensuring that their recruitment process ends up with the optimally diverse patient population that they want to study or they aspire to study. I think I have not seen anyone who sort of has nailed that yet anywhere. And I think it's a goal we all have. But I did want to highlight one other thing though in your in your description, which I think is important for people to know, again, with respect to ADA and the power of funds, is that both with respect to creating our cohort, which has now, been associated with several grant applications for larger amounts of funding from the NIH, et cetera, as well as I think upwards of maybe close to 10 papers now that have come out of this cohort, is that the ADA funds that you received were not in and of themselves transformatively large in size. But the investment that they represent in a junior scientist and in a project that has the scope to grow over time, I think that's really where the value of your ADA funding was. So the idea that, the best funds are only the largest amounts of money that go to big projects, sure, there's huge value in that. But even the so-called $50,000, per year for 2 years or 3 years kind of awards, they are also super important in this area of disparities because they get junior people to jump in and stay in this area. And that is really hard because, junior physician scientists have a lot of opposing and contrasting pulls on their time at that early career stage. And they may or may not have educational debt and a lot of other things too that dictate what they want to spend their time on in research. And getting funds from the ADA can be incredibly empowering to keep people focused on diabetes-related disparities, and these key areas of research that otherwise it's really hard not only to get the patients to enroll in the studies for, but actually hard to get researchers to want to study as well.
Yeah, that's a good point. I mean, it's not easy to stay in research, and we actually have lost a lot of good fellows that we had that we thought were going to stay and do research because of that issue with funding. So when you do research, you kind of have to have your own funding to cover your salary, or you do some clinics to help you out. And when people finish training, that's when we need that support, because if you don't have the funding, the university usually doesn't have the bandwidth to kind of keep you around. And it's really unfortunate we lose a lot of good people because of the funding issue.
Yeah, I mean that's absolutely the case. And so I would encourage folks to think about the ADA and the value of every dollar, so to speak. I've made this point again and again in different contexts, but there's really no amount of funding that is so small that we cannot do something incredibly useful with it from the research side. I mean, really, I mean, if you think about our lab meetings and the things that we're discussing, we're literally talking about $500 and how should we spend that $500, and what's the best way to take advantage of $500 for the benefit of a project that we think has merit. And so, with that in mind, I'm always impressed as to even the graduate students, people who are really new in the lab, how incredibly resourceful and respectful we are of the funds that we have access to so that we can make each dollar of funding do the very most we can possibly get it to do. And so with that in mind, I think being early in postdoctoral awards, early career diversity awards, graduate student and even medical resident level awards, our NIDDK medical student summer internships, those individuals who also come specifically from very diverse segments of the population. It's a mechanism that the NIH uses to bring them in, have all really worked a lot, at least in our lab, on projects related to health disparities, at least at a very fundamental level. And I think that lets you, I think that should let the ADA know, at least, that it's not just the big banner, large scale RFAs that matter. All of it matters, because at the investigator level, we use all of it. We sort of wring that sponge out fully of every drop of water we can get from it, so that we can really get these projects moving along.
And right, like you said, I mean, it's obviously the money for the research and like the studies that we want to do, but most of the money that I got from the ADA was to cover my salary. And the way I see it is I made it a mission to have like train more people like myself, right? So like you said, we had the NIDDK summer program. We had great students. I've done a lot of mentoring. We have another kind of meeting with one of the universities here in San Francisco to kind of bring a lot of underrepresented minority students to research. And so I think you and I have made an effort to bring kind of a diverse group of people in the lab to kind of help us answer these questions. So having the support from the ADA kind of expands to other people, kind of covers a lot of other people in the lab.
Yep. So we talked about funding, and I think at the end we're kind of trying to intersect the what do we do with what does the ADA do and what could the ADA do, kind of topically. And so there's another area that you brought up in describing, as an example anyways, your experience at in the public health facing side of UCSF. And I'm saying UCSF, but we could be talking about any large academic medical center.
Yes.
They're all connected to public health systems in their local communities, for the most part, because of the incredible training potential for medical students, residents, and fellows to learn about clinical care in the context of disparate populations by having a connection to a public health system. There's, in my opinion, perhaps no better way of getting that type of training than to be connected to a public health system. And so you mentioned the quote unquote multidisciplinary aspect of the care that's required to really make inroads in diabetes. And I know that, for example, our diabetes clinic environment at the Zuckerberg San Francisco General Hospital, our public health system in San Francisco, benefits directly from American Diabetes Association certification of our educational program, which, as you say, is really multidisciplinary. I just wanted to see if you could comment briefly on what does that environment feel like? Who do we have in our clinic there? What backgrounds do they have? What does that training feel like? Who do you talk to on a daily basis in clinic, and what are their backgrounds, and what kind of connected training environment are you able to impart on these different learners who then may one day be able to be, part of diabetes care and educational infrastructures in other settings, allowing us to sort of expand through training the number of people who learn how to do this properly all across the region.
Yeah, that's a really good point. So when I go to clinic, we have we always have medical students who are training. We have our residents, we have our fellows. Part of the clinic, we also have nurse practitioners. We have a diabetes educator. We have a nutritionist who's always in clinic helping us out. And then, so there's always teaching. There's always, we do a lot of lectures for the medical students, for the residents, for the fellows, to kind of talk about the new medications. to talk about the social issues that our patients have, because obviously when we have someone in clinic who has hemoglobin A1C, which is the marker for diabetes that we use, that is very high, and we know their diet is not good, well, it's not easy to tell someone who's homeless to just stop eating whatever they can get from a shelter, right? And so there is a lot of the social aspect that we have to be aware in our clinic. We obviously talk a lot about the medications and how we don't have a way to know what medication is going to work with which patient, and which kind of goes back to like precision medicine, but we still have to try it. And in our population, we have the issues of insurance. So if they're not well insured, unfortunately, we're very stuck with what medications we're allowed to try. And we have great medications right now to treat type 2 diabetes and obesity. And it's really hard when you cannot prescribe it to a lot of your patients because you know it's not going to be covered by insurance. So again, the medical students, the residents, and the fellows have to be aware of this. We have residents from kind of internal medicine coming in and learning a lot, and we also reach out to other clinics. So like I'm going to be doing a lecture for people who are in the HIV clinic, because we know that our HIV people who have HIV have an increased risk for type 2 diabetes. And so we're going to reach out to the HIV clinic to do a lot of teaching about what medications we can prescribe to help that particular population. And a lot of the doctors in the clinic do a lot of teaching for other clinics. So either community clinics that are outside our San Francisco General Hospital or within San Francisco General Hospital. When we have people or patients who are in the hospital, there is a lot of teaching when they're in the hospital also. And we always have a team that goes and see the consults for diabetes. And so we have students, residents, fellows, and there is also all the teaching that kind of happens bedside to our patients, right? If someone is newly diagnosed with type 2 diabetes, we need to do a lot of teaching about how to do the injections, changes in their diet, a lot of kind of the lifestyle changes. So there is a lot happening in every clinic, in a lot of aspects. But we make the point, I mean, clinics are really busy. We see a lot of patients in our clinics, but we always make the point of doing a lot of teaching and education to make sure that whoever is rotating through the clinic understands really what we need to do when it comes to medications, lifestyle changes, kind of the social economic aspects of dealing with our patients. And they can kind of take that with them to the training, to other clinics, if they're going into cardiology or nephrology. That's an important point that I forgot to mention. One of our clinics, sometimes we have our kidney doctors in the clinic. So it's really good because we can talk about all of the aspects related to poor diabetes care leading to kidney issues. And so we have that communication with the other specialties that is really important to kind of have, again, the multidisciplinary approach to help our patients.
Yeah, no, and I think that's, I ask that question in light of the fact that ADA funding supports that clinical infrastructure and certifies the approach that you just mentioned, because I think you highlight in that description many of the most fundamental aspects of disparities. Number one, there's disparities in who can get what kind of medicine.
Yeah.
Right? Not everyone can get everything. Amazingly, remarkably, medications that work for a given individual better than other medications are not equally accessible even to that individual. And even if you make the case, sometimes it's impossible to get it for that person. So how do you pivot? How do you remain resourceful? How do you find the next best approach for that person in a highly imperfect healthcare delivery system that has its own disparities with respect to haves and have-nots? The second that you mentioned early on is that there's a language element that is sometimes, you mentioned it with respect to enrolling people in studies, but even in clinical care delivery, it can be incredibly limiting. And I think, successful diabetes care environment today needs to have that multicultural and multilingual capacity in a very nimble way that they can do, right on the fly, depending on who comes in and what they need. And ADA is I think these days almost a requirement to have that the set of criteria that the ADA holds forth for certification of diabetes education programs by necessity pushes institutions to have all those elements in there. Otherwise, they can't get the ADA seal of approval. And that's very important too, because I know that the group education modules that you talked about us using at UCSF, one of the reasons why those group modules are so effective is because that way a language specific, culturally specific educator can amplify the message by communicating with many patients at the same time instead of one at a time, which would take up that individual's time. Within a day out of the week, they would be completely booked, and we would never be able to see everybody who needs to be seen. Group visit models are a very creative way to offer culturally sensitive and language specific care while also safeguarding very valuable human resources. We just don't have enough educators, and we don't have enough people who can speak all the relevant languages at our beck and call, so we can do one-on-ones for everything. You also talked about tech. Oh, sorry, go ahead, please.
Well, I was going to say that's a good point. And I think the leadership in our clinic has been really smart about this and knowing, right? So our diabetes educator is bilingual. She speaks Spanish. A lot of the people in our clinic also speak Spanish. And then we have people who speak Mandarin or Cantonese, because that's the only way we're going to reach out to our participants. I mean, there is so much you can do with a translator phone. And the other thing is that we noticed in our population that even though the Spanish speakers, we were having a really hard time getting to them and really understanding what we're trying to teach them. And we find out that some of them, Spanish is actually their second language. They speak Mayan, which is kind of another language within Mexico. And so the only person who figured this out was our very smart diabetes educator, who was like, you know what, we're having these issues. And she had to reach out to the community to find Mayan translators. And we had to get a lot of kind of the handouts that we do and a lot of the education information that we do be translated to Mayan. And so you need that kind of leadership in our clinics to be able to hire those people.
Yep.
So that's really
It's
important.
incredibly nuanced. Culture and even language we're learning is almost as nuanced as genetics is.
Yes.
You know what I mean? And I think that that indigenous populations, native populations, Mayan is reflective of an indigenous peoples, who have been present essentially forever in Mexico and other connected areas. And increasingly, we now know that that's been true for a very, very, very long time in our country. Misrecognized as Hispanic, quote unquote, or misrecognized as Mexican, quote unquote, and then being spoken to in Spanish when that's not actually their language. These insensitivities, I think, are things that limit effective care delivery. And the ADA, is providing a platform on which more visionary approaches can be undertaken. And I think that our clinic environment is an example of, the kind of more vanguard way of thinking about how to do this so that nobody gets left behind and ignored without realizing it. I think it's just important for people listening and watching today to understand that. I also wanted to mention an area that we have not spoken too much about, and then maybe pivot to one more topic in the time we have left. And again, these are all intersectional areas where funding connects to ADA research, clinical care mission, and what we actually do with respect to improving the lives of individuals with disparities. So the first area I think has to do with technology. You talked about people's internet access, people's capacity to engage remotely, and what we've had to learn. I think that's another really important area for folks to understand. It's, the point I've made many times, whether it's type 1 diabetes and we're talking about pumps and sensors, or whether it's type 2 diabetes, or whether it's just connectivity for remote virtual care delivery modules and a distributed regional approach to population diabetes management, that the inability to access technology is really, really important to recognize. So it's interesting because it's not just finding ways to make technology. It's not just finding ways to enforce insurance reimbursement for technologies and lobby for that and get that to happen. It's also understanding that there are minimal levels of technology that are highly effective. And sometimes we forego using minimal technologies in favor of thinking about the most cutting edge technology. And in the end, we actually don't use technology at all because we're unable to think about what could actually work, and the striving for perfection actually gets in the way of doing basic good. I'll give you an example of this that I think speaks to what we do in disparities right now. Our public health system and UCSF did a study with Spanish-speaking individuals looking at internet, cell phone-based video care versus old-fashioned telephone-based follow-up for patients with diabetes. And we found that the telephone-based follow-up methodology, even though there was a technology platform underlying what triggered the telephone calls, but telephone-based delivery of care for reminders, et cetera, was superior in terms of the outcomes to trying to use more cutting-edge approaches to do that same kind of remote care management, because it has to do with buy-in, it has to do with comfort, and what people are used to, what they have at home, how their internet is put forward in their home environment. Increasingly, we realize that many of our patients do not have home internet and actually use their 5G, 4G network as the only access point to internet that they have. And based on the quality, therefore, of that network and based on the quality of their phone, they may not be able to access many of the very best technology solutions for remote diabetes care delivery. So if we only use those, we will by definition treat only a subset of the population well and another subset of the population not at all. So you have to have nimbleness. I don't know if you have a moment to just comment on technology and like how you think about using technology in the area of a disparate, unequal, accessibility scenario such as you see in your care practice.
So both for clinic and for research has been really challenging. So for the cohort that we put together with Suneil, we have all these questionnaires about diet, exercise that are really important when we're trying to understand obesity and type 2 diabetes. And we created everything online. We had these great questionnaires, and then a lot of our patients couldn't access them. Some of them don't even have email, right? So that was really kind of eye-opening, how we were just like, everyone is just going to have access to the same thing, and that's not the case. When it comes to clinics, it has been really challenging. We do orientations in our clinics for weight management, for example. And obviously, because of the pandemic, we had to stop all of this. And I do the one in Spanish, and it was really challenging because our patients did not have access to, they couldn't figure out how to log into Zoom, for example. And so we had to pivot to do telephone conferences with some of them to be able to kind of explain the clinics. And that was challenging. That took forever because people got disconnected. They were at work. So little things like that. Doing telehealth at San Francisco General was also an issue. A lot of our computers didn't have cameras, for example. And when they did, then the patients didn't know how to log in. So we actually had to have someone call them before to teach them how to log in, so then we can call them and actually do the visit. But kind of what you were saying about the telephone visits, I did a lot of just telephone visits that were really challenging, where you're trying to get someone's glucometer, like glucose information for the past week. You just sit there and kind of get a lot of numbers, and the appointments took a lot longer, but that was the only way we had to reach out to them. So we sometimes, for example, in the weight management clinic, we refer our patients who are diabetics and have obesity for bariatric surgery or weight loss surgery. And they come here to UCSF for their surgeries. And because of the pandemic, now they have to do their visits online. And that has been extremely challenging to a lot of our patients because they don't know how to log into the UCSF system. They don't have an email to create an account. We tried to bring them into clinic to help them create the account, and that was not possible for many reasons, kind of more like health, private information related to their issues. And so I will have sometimes find out like 3 months later that my patient was not able to be seen in the clinic because they just couldn't figure out how to log in, how to watch the video they had to do, how to like meet with the surgeon. And so that kind of delayed their care 3 6 months. And we're trying to figure that out, right? Because there is no easy answer for a lot of our patients who have obesity or have type 2 diabetes and they're trying to lose weight. They're like really good apps to do calorie tracking and a lot of these things. And I download the app on their phone and it's in English. So if they speak Spanish or Russian or Mandarin, they cannot use it. And so we always are trying to we have our meetings and try to figure out what other app we can recommend, what else is out there. But there is definitely something to work on. That whole population needs a lot more help. We need apps
Yeah.
in Spanish and other languages because it has been really, really challenging.
So those
Yeah.
folks who are joining us, who are part of the tech community, I think it's really, hopefully you can see the incredible intricacy and all the different touch points where technology and human behavior and our funding infrastructure and reimbursement environment all intersect. It just so many points in the process that kind of get in the way. And I think it's that series of obstacles in clinical care and research that need to be overcome with an eye on diversifying our approach that creates the disparities that we're talking about, being emblematic of of diabetes landscape in the United States. I'll just make a few summary points, and then maybe we can touch one more topic briefly before we conclude. One is that, and this is for folks who are joining us. One is that academic medical centers have an obligation to train. In the traditional model, we would train the residents, the students, and the staff, as well as faculty members training one another among the people who are at our institution. Increasingly, though, we know that what we are also training people in is to see our model of care delivery and learn our model of care delivery. Because, for example, our advanced practice nurses who rotate with us, they don't stay at UCSF for their careers. They go practice elsewhere. And when they practice elsewhere, particularly if they practice in rural settings, which many of them end up doing, they're the most knowledgeable person in that practice environment that they end up going to. And so the ADA supporting an educational module in an academic medical center, that funding ultimately links to a knowledgeable nurse practitioner in a very rural area somewhere far away from our city center doing a really good job in a resource deprived care scenario. So that amplifying effect is something that I think people need to appreciate, that supporting through the ADA efforts like ours, creates. The next thing I think that I wanted to just make sure people understood is that that idea of that Deanna highlighted, where we are unable to connect with people in the end. We realized after the fact that there was a barrier, and that's why the person, quote unquote, never came back to clinic or never ended up coming back for their second visit in a research study or something like that. This loss out of the system is also unequal. I mean, some segments of the population fall out altogether much more frequently than do other segments of the population. And loosely, we've created a term we call diabetes distress to encapsulate the psychological burden that people feel that makes them put their hands up in the air and say, you know what, I'm done with this. I don't care anymore about this diabetes business because it's just too much work and I can't do it. Well, diabetes distress is not an individual mental health deficiency. Disparities and social determinants of health dictate the likelihood that someone will end up reaching the end of their rope in that regard and develop what we call diabetes distress, which can even proceed to frank depression. So disparities research inherently involves understanding what those factors are and how they can coincide with mental health, so that we can empower people to feel good about engaging in their own diabetes care and the self-care that goes with it, and not then lose people to follow up, which is inherently traditionally been the case.
Yeah.
And then lastly, I would like to just make the point about this idea that diabetes research is about funding, quote unquote, a cure, or funding, quote unquote, the treatment for me. That's discovery biology and the translation of discovery biology. It is incredibly important. But part of disparities research and disparities in general is about making sure that everybody benefits from the technologies, the research, and the discoveries that we have already made, not just the idea of making new discoveries. And I think that's really important as well. And the ADA has RFAs out right now for diabetes disparities research. And part of what we're aiming to do is to encourage diverse groups, including clinical researchers, clinical care delivery groups, as well as translational and very basic fundamental biologists, to focus on how do we equalize the benefit of what we already spend so much time doing, so that our most vulnerable segments of the population receive the benefits that they rightly deserve from all of that research that goes on.
That's a good point. I mean, as I do, and you also, basic research, translational research, but education is really important, right? So, like you say, we have a lot of resources, and a good number of patients don't even understand what diabetes is. They don't understand what they need to do. They don't understand the basics. I'm amazed when they come to clinic after 10 years of being a type 2 diabetic, and I sit and talk to them about why drinking soda or juice is bad for them, and they're like, oh, I thought juice was great, I had no idea. So no one had the time to sit with them, and or they didn't have access to the resources to talk to a dietitian, to a diabetes educator, to sit for like 45 minutes with a doctor to explain all these things. And so, as much as you said, there is great research going into medications. We have great medications, but we can go back to the basics and say this person needs like an hour with a dietitian every time they come, because they don't
Yep.
understand a lot of the issues when it comes to a diagnosis of diabetes.
Agree. And similarly, you can get the blank stare issue, and we need to do everything we can to prevent that. For example, a dietitian telling a patient that they need to avoid sugar cereals and white bread when that individual has never eaten traditional Western cereal or white bread ever
Yeah.
in their life,
Right.
can lead to a sort of break in the communication that will never corrects itself. So, the idea that tortillas are a staple in some diets, how do you talk about carbohydrates in the context of that traditional cultural staple? In some cultures, white rice is a staple. How
Mhm.
do you talk about carbohydrates in the setting where white rice is an absolute cultural staple?
Right.
These things require nuance, and that's some of what the ADA, is at letting places like us really teach about.
Mhm.
And then in the last maybe minute or two, I just want to bring it back to the lab, and bring it back to the translational biology. I was part of a study through UCSF, where we looked at all 5 of the large UC medical centers. So now we're moving beyond UCSF and talking about the UC system as a whole. And in this study, we looked at prescribing patterns for patients who were taking metformin as a monotherapy for diabetes. And you could see large patterns of similarity across all 5 medical centers, in terms of like who was prescribed only metformin, who was prescribed metformin plus insulin, who was prescribed a number of other ancillary medications that are less frequently prescribed. It made sense.
Mhm.
But then we tracked individuals in 90-day increments out from the initial prescribing decision. And what we found was that within 90 days, and then 180 days, and then 270 days, it looked like people were throwing darts at a dartboard. I mean, it was just random appearing what combinations and permutations of diabetes medication additions, swap outs, changes, etc. were being made. There did not appear to be any kind of pattern, although individual prescribers seem to have their own way that they like to do it. what dictated the way they like to do it, why they did it the way they did it, why it was different than the prescriber in the office right next door to theirs did there's no clear understanding of any of that. So one of the things I think that the ADA can help with also is to help fund research that utilizes computational approaches, really powerful computing efforts to take advantage of electronic health record data to sort of disentangle this seemingly randomness and create patterns in it, understand what types of treatment approaches work for what types of people, and then allow scientists like us to look at the basic biology of those individuals to try to understand the biological factors that make people more responsive to one type of medicine and less responsive to another type of medicine, so that we can immediately pivot to a world where we have precise diagnostics that will let a practitioner say, oh, this person has a test, this panel shows a certain pattern, I should immediately start this person on this medicine from day one. It's the one that's most likely to work for them. And that's aspirational, but that is completely approachable. Given the immense bioinformatic and computing capacity we now have to approach clinical records that are huge in size nowadays, and couple that with basic biology. And that's kind of what we're working on, is the basic biology side of this that separates individuals from one another in terms of responsiveness to diets, responsiveness to exercise, responsiveness to specific medicines. And so maybe in the last minute or two, you can just let us get a sense of where you think that field is.
That's a really great point. I mean, we have so much data when it comes to the clinical data that we have, as much as also genomics data, right? I mean, we can kind of put everything together. And I think when you think about cost, yes, some of the medications we have right now are extremely expensive, but we're probably going to save more money if we're able to figure out that medication works for that person, instead of trying 5 different medications for a couple of years and letting that person have eye problems or kidney problems because they were never well controlled.
That's
so
right.
If we can just go directly to that medication, long term, I think cost wise, it makes a lot of sense.
Yep. So disparities research doesn't just focus on making sure there's equality. It also has a forward-thinking, research-oriented element for precision. That's the other aspect of what we can strive for in disparities research, is precision and customization. And I think that's really where research is going. And I think the ADA does well by funding that area of research as well. So I will stop there and let folks know that if they have questions, because we wanted to cover a lot during this hour, they can send those in and we can provide answers to people by email with respect to their questions.
Great.
Thanks, everybody. Thanks for joining. We really appreciated it.
Thank you.
That was a terrific panel. I'd really like to thank our moderator, Dr. Suneil Koliwad, and our panelist, Dr. Diana Alba. Again, this is a fundraiser, so I'd like to remind you that this is your opportunity to support our cause. Please, I want to make sure that you support the ADA mission to cure diabetes and improve the lives of everyone who is affected by it. Please go to diabetes.org/leaders-donate to make your donation. I'd also like to invite you to join us at the Inclusive and Accessible Health Technologies discussion with Dr. Bob Gabay of ADA, Badia Boudifa of Abbott Diabetes Care, and Red Maxwell of Bigfoot Biomedical, which will take place 9 a.m. on November 16th on this very platform. So please come back and join us. Also, join us November 19th at 10 a.m. for the Leaders Forum Health Tech Showcase. That will be in person this year. You can purchase tickets at diabetes.org/leadersforum. I hope you'll join us there. I will be the MC. It's going to be a terrific time. You're really going to enjoy the showcase and, of course, the competition. Thank you so much for supporting us, for supporting diabetes, for joining this cause, and for joining us here today.